Uh, I'll start with some maths. I have 9 questions and a case. Case will be about 7 to 8 minutes. And 9 questions means we have 2 minutes per question, because total time available is only 30 minutes. Okay. I have already distributed the questions to the panelists. So I expect sharp 1-minute answers, not very lengthy answers. The pie diagram on the right side of the slide shows the etiologies of chronic liver disease in our wards at Bhubaneshwar. And there are 2 diseases which are vying for the first position. I'm told the similar situation is there in almost all the medical colleges and hospitals. But there are times when these 2 diseases intertwine with each other, and one such case I'm bringing it here. Before objecting, Deepika, kindly read the footprint. It's not a patient's picture. 47-year-old lady who was a COO of a private company reported for a dull aching pain in the right upper quadrant and lack of appetite. She was a diabetic for last 6 years and was taking metformin and sitagliptin. About alcohol, she said that I take occasionally, only socially. Her BMI was 32.4. She was active and had no sarcopenia. Clinically, there was tenderness in the right upper quadrant. And these are the things which were sent by the referring doctor to us. The ultrasound showed hepatomegaly with grade 2 fatty liver. There was increased visceral fat. Gallbladder was normal. And the investigations are shown here. Provisional diagnosis given was NAFLD. And Anand, can you tell me what is your impression about the diagnosis and what further step will you take?
So since there is consumption of alcohol and AST more than ALT, I would be still skeptical whether it is NAFLD or not. I will be digging on more history about alcohol intake.
Excellent. I was less confident about confronting her about alcohol history, so I did some of the tests again. And the suspicions which Anand Kulkarni has brought out were confirmed. She had macrocytosis. Her GGT was quite raised. So we questioned her again about the alcohol intake. She denied daily drinking. She says, I'm always within limits. I take 1 drink, at the most 2 drinks, and mostly on social occasions, which are only 1 to 3 times a week. Sometimes I take little more, that is 3 to 4 drinks on a weekend, but that weekend comes once in 1 or 2 months. Husband mostly accompanied her in the parties, and he agreed with her assessment. There were no colleagues available. So my question number 2 is to Arun. How will you decide whether this is a significant alcohol intake or not?
First thing we have to remember is that most people underreport their alcohol intake. She being the person being a female and of high BMI, this alcohol limit would be serious. Third thing about this history is she has got weekend binge drinking, which a recent study that is published in 2022 has said that binge drinking, especially in the weekends, has increased alcohol-related mortality.
It doesn't reach the definition of binge drinking.
Yeah, but there are other risks that she is having along with that, and she has a borderline low platelet, and her fibrosis score is also high. So I would consider that as a significant drinking pattern.
Okay. There are other methods of finding out. For example, recently there was a paper published about ethyl glucuronide in the hair samples or in the urine. And also there are other methods by which we come to get to know. For the regular use, we already have MCV and gamma GT available with us. The other tests which can be done are also listed here. Unfortunately, we did not do any of these tests. And I'll just project one slide to show what is the current definition of NAFLD. It is based on exclusion of alcohol. And exclusion of alcohol, the limit of alcohol which is permitted to these people has been varying with the varying studies which have been published. Some people said that it should be zero amount of alcohol. Some people said that 140 grams of alcohol per week is permitted. And then we have 21 wise people getting together to tell us how much it should be. For example, in ASLD, it says that 294 grams per week is permissible for males, and 196 grams per week is permissible for females. In India, of course, they would be considered alcoholics. So, question is whether these recommendations are evidence-based. What is your opinion, Akash?
So, the definition for alcohol intake standardization is not evidence-based. Not only does the amount of drink vary, but also what is significant alcohol consumption also varies. If you see definition from Japan, Australia, USA, UK, they're all variable. And this cutoff of 14 and 21 comes from an old Scandinavian data where they had, which was the retrospective analysis.
So that means that NAFLD cannot be accurately defined. Okay. My next question is, can Hodgkin's lymphoma and non-Hodgkin's lymphoma coexist?
Well, yes, biologically it is possible, but
it's never been reported.
We need to have molecular tests for
it has not been reported. Normally, we give a justification of using a negative nomenclature for NAFLD by saying that we already have non-Hodgkin's lymphoma. But problem is, non-Hodgkin's lymphoma does not coexist with Hodgkin's lymphoma. But NAFLD, can it coexist with alcoholic liver disease? So that is the audience poll question right now. Is alcohol-associated liver disease and non-alcoholic liver disease in this patient? What is she suffering from? Is it AALD, NAFLD, or BFLD? Can we have an audience poll? So audience is baffled. Dr. Chaudhary, would you like to comment? Is it logical to have a non-alcoholic liver disease in which alcoholic liver disease is also there?
Much of the things in life don't go on logic alone. So I mean, it's common sense. I think that there is a factor, both the two factors are operative. Very difficult to actually tweak one from the other in this scenario. Very difficult.
Okay, so let's go to the next question then. We now need to find out which is the dominant disease in this. Is it alcoholic liver disease which is dominant, or it is the non-alcoholic liver disease which is dominant? And how will we decide that? Can I ask Anand whether physical examination will help?
A firm enlarged tender liver may be suggestive of alcoholic hepatitis since there is elevation in enzyme, but physical examination per se may not.
But you can have tenderness even in the non-alcoholic fatty liver disease.
Tender liver in NAFLD is less likely, and high BMI, high waist circumference probably points more towards metabolic components. So, alcohol-associated fatty liver disease with metabolic component.
All right. I agree with you. There are no symptoms and signs which will exclude a disease. There are some symptoms and signs which will suggest that it is possibly insulin resistance is a dominant factor here, and it can be NAFLD, or the patient has signs of chronic alcohol use, and that may be alcoholic liver disease is present, but nothing can exclude the other disease. And therefore, the possibility remains that which is dominant, we cannot find out from the physical examination. What about imaging, Arun?
Imaging, it's there are not really. There is one proposed sign which I have not seen in my practice. Is kind of something called as a pseudo-parallel sign in acute alcoholic hepatitis. But by and large, clinically, to differentiate NAFLD and ALD by imaging is difficult.
There is a study which has recently been published. It shows that alcoholic and non-alcoholic steatohepatitis, vascular branching heterogeneity on MRI is a diagnostic marker for alcoholic liver disease. And they have identified perivascular branching pattern on imaging, which they say is a promising novel diagnostic marker that can be used with other methods to help distinguish alcoholic steatohepatitis with NASH, but whether it can exclude the other is not reported. Then there is also use of AI, that is deep learning supports differentiation of alcoholic and other. This particular paper from Nature has studied 4 protocols of deep learning, and they said that the proof of principle study shows deep learning classifiers have the potential to aid in discriminating liver cirrhosis etiology based on standard MRI. Any comments on that, Dr. Chaudhary?
So basically, the AI techniques are, depends on what data they have been trained on. If there is no gray zone in the data, the clear-cut cases and controls, then it is going to overestimate the accuracy of a model. So that is what we need to look at.
So I don't think even that can differentiate between the two.
Yes, so we need to have, and there are emerging data, molecular-based techniques, different forms of cell death, different types of microbiome in patients with ALD versus non-alcoholic fatty liver disease. So we need to go probably deeper into the biology of patients.
Okay, Nipun, next question is for you. What is the role of liver biopsy in differentiating between the two?
Grossly, there is fatty liver in both the situations. So certain features which may tend more towards alcoholic liver diseases like central hyaline necrosis, perivenular fibrosis, or maybe, the cholestasis. These are findings which are very peculiar to alcoholic liver disease, may not be seen in pure non-alcoholic fatty liver disease patients. And I think, and microvesicular steatosis sometimes can be very severe in patients with alcoholic hepatitis, which alcoholic liver disease not probably seen in non-alcoholic fatty liver disease. But grossly, the finding, and the neutrophilic infiltration, which is predominant in patients with alcoholic liver disease. So these are the certain features.
Okay. There is a Dr. Sakhuja's paper which says that one can differentiate, looking at the histology, whether it is a predominantly alcoholic damage or it is a non-alcoholic damage. What would you say to that?
What is the question, sir?
This is Dr. Pooja Sakhuja's paper, which says that you can differentiate between alcoholic and non-alcoholic fatty liver disease on histopathology.
I think it is the predominant phenotype based on history examination and the biopsy which makes the clinical diagnosis. So this is something which has been described. Yes, it can be helpful for making the diagnosis.
Okay, I agree with you that you said that hepatic canalicular cholestasis more likely to be present in alcoholic cirrhosis, alcoholic steatohepatitis. Similarly, bile ductular proliferation, sclerosing hyaline necrosis. These are more commonly seen with alcoholics. On the other hand, mixed macrovascular and microvascular, as you said, is more likely to be in a non-alcoholic fatty liver disease. A lobular inflammation and nuclear vacuolation, apoptotic injury, more likely in the non-alcoholic fatty liver disease. Okay, next question is, when do we do liver biopsy in this situation? Should we do liver biopsy in the patient that has come?
Just to prove that's all, otherwise, just to prove that it is alcoholic hepatitis, otherwise I would not be doing in patients and outpatients unless I'm planning for steroid therapy.
No, the clinical picture is with you. With this clinical picture, would you like to do a liver biopsy?
No, sir. I would like to do a ANI scoring, alcohol,
okay.
NAFLD scoring.
So let's go to then ANI scoring. Akash, what is the role of ANI scoring? It has been described some time back, quite an old paper.
Yes, it's quite an
and
old
in
paper.
Clinical practice, how often it is used?
So it's quite an old paper, came out of Mayo. It was originally was a biopsy proven, and then they had compared. It uses 4 components: ALT, AST, MCV, age, and BMI, 5 components. This works good. I've been working on this around 400 odd patients. I think we'll present this at INAZL. But this has 2 limitations. Number 1, if somebody's lean and has got fat, doesn't take alcohol, this classifies them as alcoholic fatty liver. And the other side, if somebody is a female, is obese, consumes alcohol, still it classifies as non-alcoholic fatty liver disease. I calculated the score yesterday for this case itself. It gives a score of 2.6 and probability of only 6% to have an alcoholic fatty liver disease. So the score is good, but it has got its limitations, and it caps off the MCV at 92. So even the MCV was 103. We put in the calculator, it will still come out to be 92.
No, my calculation was different.
My
So
calculation was different.
So there's a small change addition. The cutoffs are two. There is an upper and a lower ceiling. It's 92 and I think 103, and there is a cutoff of 3 times for AST. So if you apply that, then it's okay.
My calculation was alcoholic liver disease in
Yes,
this patient.
this patient
97% probability of alcoholic liver
I
disease.
think the difference is because there were 2 reports available, and you may have used the reports which
Yes.
were sent by the GP to us, and you may have used the reports that were done at our hospital. And I agree with you that alcoholic steatohepatitis is what is shown by the calculation here. So do you think that if the patient has alcoholic steatohepatitis, she needs treatment only for alcoholic hepatitis and not really treatment for non-alcoholic fatty liver disease?
No. I guess this is very clear that we need to treat both the cofactors in a given patient to have better outcomes.
So without deciding which is a predominant disease, would you like to embark on treating both together?
So the both factors are playing in the pathogenesis of a patient. So I feel we need to do an abstinence, we need to do a physical activity, and the diet and the lifestyle changes similar.
Okay. Akash, what is your opinion on this?
I agree on this.
You don't need to differentiate, you need to just treat.
So by definition, this, if you see the original reports, it does not fit into the clinical diagnosis of alcoholic hepatitis. So I think we have to manage both of it and not individually focus on the individual part of it.
So
Arun?
both the metabolic component also drives the disease, the fibrosis or the steatosis, and the alcohol can drive. So both are synergistic and the effects are bidirectional. So I think for this particular patient, you have to address both the things.
Okay. Before I come to the last question, there is another question which I have. What is the impact of alcohol on NAFLD? Yes, Anand.
Sir, previously they used to say that 20 grams light consumption less than 10 grams is useful, beneficial, but recent reports suggest that 0 intake should be maintained for NAFLD patients to have a better prognosis.
Any other
And
opinion?
We suggest 0 consumption.
So well, it is the type of drinking also has been reported that wine could be safe and probably protective. Mouse studies at least have shown, but any intake beyond 10 grams has been shown to be harmful for overall health. Global burden of disease have reported that in terms of cancers, in terms of progression also. At least it is very, very clear in patients who are having having alcoholic liver disease, presence of obesity and high BMI is directly correlating with the increased progression of fibrosis, cirrhosis, mortality, HCC. That is very, very clear. But in a patient with established NAFLD, moderate amount of alcohol is still controversial. The binge drinking is probably more harmful in such group of patients.
But I'll repeat, this lady did not, by definition, go in for binge
Sir,
drinking.
if I take the NITRIPL definition,
I think we should go for the Canadian guidelines, which have come out of late. I think any amount of alcohol is injurious. I think it is our duty not to tell patients to continue with alcohol intake, even if you think it is NAFLD with less than 20 grams. We do not know what is the impact of even less than 20 grams. But based on these Canadian guidelines, in relation to overall mortality, which you mentioned, the risk of cancer, it starts from 10 grams. So why do you expect a person to drink and expose himself to cancer in the presence of a disease which is likely to develop into cancer, both NAFLD and alcoholic liver disease? I think we have been discussing on a subject
Personally, I
which
agree
is
with
a
you.
really a gray area. To me, whether you call it NAFLD or an alcoholic hepatitis, it requires aggressive treatment.
Dr.
That is the
Chaudhary,
bottom
can we reverse the question? What is the effect of NAFLD on alcoholic liver disease?
You're asking me. See, here I'll tell you, we are debating it as scientists, okay? Practically what I would do in the clinic, I would ask this lady to just invest 6 to 8 weeks of stopping alcohol and trying to see what happens to the liver enzymes. the chances are very good that in 8 weeks' time it might come crashing down. And after that, if she's comfortable continuing, fine. If she wants to explore and still retry drinking and it shoots up, it more or less drives home the point. And I think sometimes it's a much more convincing evidence than to even do a liver biopsy.
Okay.
Sir, one more point I would like to say that if there is an underlying severe fibrosis or significant fibrosis or advanced fibrosis, any amount of alcohol is going to be very, very injurious in the patient. So
I agree with this
Sir,
point.
this is very clear.
One additional submission. In patients with cirrhosis, in patient with high fibrosis, or in patient with multiple comorbidities which can drive the disease, we all know the answer that the alcohol is not safe. The only problem is lifetime, people who are teetotalers or people who have mild drinking and no comorbidities. That is the only gray area we currently have. In these people, our advice should be that there are far more better ways to reduce CV risk than consume alcohol. That should be, as doctors, a medical opinion should be that there are far more easy, heavily available things to reduce CV risk, like exercise, and the amount of whatever the wine or whatever is required for CV risk protection is too much. So I don't think we should be recommending alcohol at any level to any spectrum of the disease.
I actually feel hesitant to show the paper that I have to show you because there are about 200 people here and they all blindly believe what Dr. Arun Sanyal says. And he says that modest alcohol consumption is associated with decreased prevalence of steatohepatitis in patients with non-alcoholic fatty liver disease.
So we need his opinion, sir.
Sir, to just add, sir, I may be wrong, sir. I'll pose this question to Dr. Sanyal himself.
We will talk to him.
This study had excluded binge drinkers.
No. We will. That's a different group together. But
Yeah,
I'm telling you, the title of the study is this.
To draw conclusions.
And in addition to that, this is not the only study.
Yes.
There are other studies as well. This is, for example, who consider alcohol as a nutrient. The paper is Nutrients, and it says moderate alcohol intake in non-alcoholic fatty liver disease, to drink or not to drink. And then he goes on to quote 15 studies where the benefit has been shown, both in terms of reducing the steatohepatitis as well as reducing cardiovascular mortality. These are the 4 studies here, another 4 studies here, another 5 studies here, and another 3 studies here.
The problem is they don't stop at 10 grams, 20 grams. Once they start, there is no end. Even the ALD patients.
Sir, this would be practical in a patient who's been provided trial packets of alcohol.
So I think this is addressed.
Nipun, what is your opinion?
I think, sir, what other things patients is consuming apart from alcohol is also very important here. There has been a study which showed that, if the patient is consuming in moderate amounts of alcohol, and a Finnish study actually showed that they were consuming a lot of green vegetables and fermented foods together.
I think I'll skip the discussion because only 1 minute is left. But the summary of both the studies said that this data is not reliable.
Not
And the bottom line is the data is far from solid, and possibly we should be relying on larger data, better collected. And there are 2 studies which people are now talking about. One is this, which was published in Lancet, and which showed that all-cause mortality rises if you're taking more than 100 grams per week. And the second study is published in BMJ Open, which says that this review found that any level of alcohol intake and NAFLD may be harmful for the liver health, as Dr. Shinai was saying. Based on this synthesis, the most up-to-date longitudinal evidence, clinicians seeking patients with NAFLD should currently advise total abstinence from alcohol. So I want this to be clear, and don't go by the earlier paper that I presented from Dr. Sanyal. Last question is, as I mentioned, that if you define non-alcoholic fatty liver disease by absence of alcohol, how can you say that it can coexist with alcoholic liver disease? Wouldn't the nomenclature of metabolic dissociation associated fatty liver disease sort out this confusion? I want to have an audience poll on this. audience says that we should use MAFLD rather than NAFLD.